Blood pressure is often treated as the ultimate barometer for adrenal insufficiency, yet the common belief that low cortisol always equals low blood pressure is a dangerous oversimplification that ignores how the body actually functions under stress. While it is true that adrenal insufficiency can lead to hypotension, the cardiovascular reality is far more complex, involving a delicate interplay of vascular tone, fluid volume, and high-stakes compensatory mechanisms that can sometimes drive blood pressure up even when cortisol is bottoming out.
It is essentially a physics problem at its core. If we look at the fundamental equation, blood pressure is roughly equivalent to cardiac output multiplied by systemic vascular resistance, or SVR. Cardiac output is the volume of blood the heart pumps per minute, heart rate times stroke volume, while SVR represents the resistance the blood vessels provide against that flow. In a healthy system, these variables dance together to keep you stable. In adrenal insufficiency, or AI, the music stops, but different instruments fail depending on which type of AI we are talking about.
That distinction between the types of AI is where the confusion often starts. Most people hear adrenal insufficiency and think of Addison's disease, which is primary adrenal insufficiency. In that case, the adrenal cortex itself is damaged, meaning you lose both cortisol and aldosterone. But in secondary or tertiary AI, or even steroid-induced AI, the problem is further up the chain in the pituitary or hypothalamus. In those cases, aldosterone is generally preserved because its production is primarily regulated by the renin-angiotensin-aldosterone system, not just ACTH.
And that is a massive physiological divide. Aldosterone is the body's primary mineral corticoid. Its job is to tell the kidneys to hang on to sodium and water while dumping potassium. If you lack aldosterone, like in primary AI, you are literally leaking volume. Your blood pressure drops because the pipes don't have enough fluid in them. But even if your aldosterone is fine, as in secondary AI, you can still struggle with blood pressure because of how cortisol affects vascular tone.
This is the permissive effect that often gets overlooked in patient education. Cortisol isn't necessarily the one tightening the blood vessels directly, but it acts like a technician making sure the receptors for other hormones are actually plugged in and working. According to research on glucocorticoids and vascular reactivity, cortisol is essential for the vascular smooth muscle to respond to catecholamines like norepinephrine. It influences alpha-1 adrenergic receptors and helps modulate nitric oxide and prostacyclin.
Think of it as a radio receiver. The body sends out a signal, norepinephrine, telling the vessels to constrict and raise pressure. If cortisol is missing, the volume on that receiver is turned way down. The signal is there, but the vessels can't hear it properly. They stay dilated when they should be tightening. This is why AI patients can experience orthostatic hypotension, where standing up causes a sudden drop in pressure. Gravity pulls blood toward the legs, and the body's usual lightning-fast correction fails because the vascular responsiveness is blunted.
But the body doesn't just give up when it detects a drop in pressure. This brings us to the second part of the equation, compensation. The baroreceptors in your carotid sinuses and aortic arch are constantly monitoring the stretch of your arterial walls. The moment they sense a dip, they trigger the sympathetic nervous system to fire. This is often what patients describe as an adrenaline dump, that wired and weak feeling where the heart is pounding and the hands are shaking, but the body feels like it's failing.
The term adrenaline dump is descriptive, but medically we are looking at sympathetic activation and the release of catecholamines. Norepinephrine comes from the sympathetic nerve endings to tighten vessels, while epinephrine, or adrenaline, comes from the adrenal medulla. Here is a fascinating biological detail. The adrenal cortex actually wraps around the medulla for a specific reason. The enzyme that converts norepinephrine into epinephrine is called PNMT, and it requires high local concentrations of cortisol from the surrounding cortex to work.
So if the cortex isn't producing enough cortisol, the medulla might not be able to produce enough epinephrine. It is a double-edged sword. You have this massive sympathetic drive because the body is panicking about low blood pressure, but the actual adrenaline response might be blunted. This creates a physiological paradox where the sympathetic system is screaming for more pressure, and that effort can actually drive blood pressure to normal or even high levels, even if the patient is in a cortisol deficit.
This is why the phrase compensation does not equal stability is so vital. Imagine a car driving up a steep mountain at 55 miles per hour. To the person looking at the speedometer, everything looks normal. But under the hood, the engine is redlining, the transmission has downshifted, and it's burning fuel at an unsustainable rate. A normal blood pressure reading of 120 or 80 might be the result of a body working at 200% capacity just to keep the lights on. The cuff measures the pressure, not the effort required to generate it.
That explains why a high blood pressure reading doesn't automatically mean a patient has enough cortisol. If the body is using every ounce of sympathetic drive to compensate for a lack of vascular tone, the resulting high blood pressure is a sign of stress, not a sign of health. It also debunks the idea that an adrenaline dump always proves low cortisol. High blood pressure and racing hearts happen for dozens of reasons: pain, anxiety, fever, dehydration, or even just too much caffeine.
Exactly. We have to move away from the idea that blood pressure is a cortisol meter. In the third part of this deep dive, we really have to look at the non-adrenal factors that muddy the waters. For example, pain itself is a massive trigger for sympathetic activation. If an AI patient has severe back pain, their blood pressure might skyrocket. If they assume that high pressure means they have plenty of cortisol, they might miss the fact that the pain is actually increasing their body's demand for cortisol.
And then there are the medications. The American Heart Association notes that everything from NSAIDs like ibuprofen to birth control and certain antidepressants can raise blood pressure. Conversely, diuretics and anti-anxiety meds can lower it. For someone with AI, their replacement doses of hydrocortisone or fludrocortisone also play a role. The Endocrine Society's guidelines for primary AI specifically mention that hypertension during fludrocortisone therapy needs careful evaluation. It might mean the dose is too high, or it might just be coexisting primary hypertension.
We also can't ignore other comorbidities. Autoimmune Addison's often travels with autoimmune thyroid disease. Thyroid hormones have a direct impact on heart rate and how the heart contracts. Kidney disease, sleep apnea, and autonomic dysfunction like POTS all influence these same numbers. If we label every fluctuation in blood pressure as an adrenal issue, we risk missing a serious secondary condition like sleep apnea, which the National Heart, Lung, and Blood Institute links directly to difficult-to-control hypertension.
Measurement technique is another huge variable that gets ignored. If you're checking your blood pressure while sitting with your legs crossed, or if your arm isn't supported at heart level, you're getting bad data. The CDC emphasizes that even being nervous or having a full bladder can skew the results. If you base your life-saving medication decisions on a single, poorly taken reading, you're flying blind. A single snapshot isn't a movie. You need to look at your personal baseline and the overall trend.
That personal baseline is everything. If someone usually runs 90-60 and they suddenly hit 130-90, that is a significant hypertensive event for them, even if a doctor might call 130-90 pre-hypertension for a member of the general public. Conversely, a long-standing hypertensive patient who drops to 110-70 might be in serious trouble. You have to know your normal to understand when the system is deviating.
It all leads back to this four-part summary that every patient and provider should internalize. Low blood pressure does not prove low cortisol. Normal blood pressure does not prove adequate cortisol. High blood pressure does not prove adequate cortisol. And high blood pressure does not prove an adrenaline surge caused by low cortisol. It is information, not a diagnosis.
It's about avoiding two dangerous extremes. The first is, it's probably just your AI, which ignores the rest of human physiology. The second is your blood pressure is normal, so it can't be AI, which ignores the reality of compensation. If a patient is experiencing symptoms of an adrenal crisis, nausea, profound weakness, confusion, they need to follow their emergency plan regardless of what the blood pressure cuff says. You don't wait for the car's engine to explode before you notice the temperature gauges in the red.
The cardiovascular system is remarkably resilient until it isn't. In a true crisis, that loss of vascular tone can eventually lead to what's called vasopressor-resistant hypotension, where even standard emergency meds struggle to raise the pressure because the receptors just aren't listening without cortisol. That is the life-threatening end of the spectrum, but the path leading there is often paved with normal-looking numbers maintained by intense physiological work.
This really highlights the need for individualized care. Because the interaction between cortisol, aldosterone, and the sympathetic nervous system is so specific to each person's body and their specific type of AI, there is no one-size-fits-all reading. Working closely with an endocrinologist to map out how your body responds to stress, salt, and heat is the only way to build a reliable safety net.
We've covered a lot of ground, from the permissive role of glucocorticoids on catecholamines and the importance of aldosterone in primary AI, to the way the sympathetic nervous system can mask a deficit through high-effort compensation. Understanding that blood pressure is a clue rather than a definitive meter allows for a much more nuanced and safer approach to managing this condition.
It is about becoming a student of your own physiology. If you can distinguish between a simple volume drop and a full-blown sympathetic compensatory event, you are much better equipped to communicate with your medical team. The science shows that our bodies have these incredible backup systems, but we have to be smart enough to recognize when the backups are the only thing keeping us upright.
Everything we have discussed today is for educational purposes and should not be taken as medical advice. Adrenal insufficiency is a complex, life-threatening condition that requires a personalized management plan developed with your healthcare provider. For more in-depth resources, check out the My Adrenal Life website and the work of Rick Dissler. If you found this breakdown helpful, consider sharing it with someone else navigating the complexities of adrenal health.